we will be discussing a synthesis of the chapters in Giddens for week 4, module 4. And the chapters entail chapter 20, 26, 29, and then I have preoperative care here. Just remember, preoperative care is not included in Giddens. It's actually included in the Pearson's textbook, which you were not required to purchase this semester, but next semester in Nursing 138, you are required to purchase it. But I do have some articles that will better explain preoperative care, and then you can also refer to ATI as well. That way you can get a better grasp on what it means. So here are the learning objectives. All right, so concept of perioperative care. So just remember there are 3 phases, which are preoperative, intraoperative, and postoperative. RNs are not expected to know about anesthesia or the intraoperative period, except to recognize that the RN can be a circulating nurse in the OR. And we briefly talked about this when we did labor and delivery, right? So we did say that if the patient has to go for a C-section, there will be an RN that will be the circulating nurse that will be assisting in the OR. And there are actually a first nurse. So this first nurse is actually considered an advanced practice nurse that will assist with any type of surgical procedures. So remember, this advanced practice nurse received all of the training. So that way they can, assist with any surgical procedures. But you, as the registered nurse in a perioperative environment, need to understand what true sterile procedure is. And, we've practiced in lab on how to put on sterile gloves on anything, below the waist is contaminated. So the true sterile process is important to understand as well, because when a client is on the operating room and they're open, they're at risk of infection. So any microorganism that enters the open wound will result in an infection. So we have to be as sterile as possible in the operating room. So anything below the OR bed is considered non-sterile. So that's important to keep in mind. So if you go to this preoperative article that is provided in the slide, you will see that the orange roll is what they use for the red flags before surgery. And this can be abnormal electrolytes, let's see, failure to follow NPO status, or bowel preps, or their gait, their use of adaptive devices before OR. So again, this is preoperative. Their incontinence of bowel or bladder, and finally their caregiver, right? Will this patient have a caregiver that will be home, that will assist them in the recovery process? So that's important as well. Post-operative complications occur more commonly in our older adults, such as AFib, and those usually are people who are obese or have other conditions such as hypothyroidism, or let me think, men, clients with hypertension or those with high preoperative heart rate, And there is a good table in this article, table 1, that will help you with that. Delirium is also very important to understand during post-op because of what the client takes during anesthesia, such as, anesthesia medications, opioids. All of that can cause delirium in our clients. And then the venous thrombus embolism, which is VTE, an acronym for that. That is common as well. It's another complication due to the age and stasis of blood flow, right? The client is stationary, non-moving, so that blood flow will pull. So we will have them on medications during post-op on blood thinners, um, which is why sequential compression devices are important. Low dose heparin injections, such as Lovenox, is important as well, to help prevent a clot during post-op. Hypothermia is something else to consider as well, and it is common in our older population, which can cause electrolyte any abnormalities with electrolytes, that can, cause skin breakdown, right? Increase infection as well. And just remember, there's a question here on perioperative care. So make sure you answer that. And just remember the stem of the question: what is the nurse's greatest concern about this client? Okay, so make sure you turn in your lab before your document before Sunday. All right, your next concept here is clotting. So the definition is when blood physiologically changes from a liquid to a semi-solid gel. In the normal clotting process, the damaged vessels, platelets, and clotting factors work together to stop the bleeding. Do you have to know the entire coagulation cascade? Is a question I'm asking, and the response is no. But you need to understand that there are many different factors involved with the coagulation process, with the clotting process. The first response usually results from an injury, which could be a surgical injury, right? Or an actual injury such as a needle stick injury. And the first response that our body will perform is vasoconstriction, which reduces blood flow, allowing the blood clotting process to start. Bleeding is slowed further when the blood is pulled surrounding the blood vessels, creates pressure against the walls of the affected vessels. The second response is triggered by a damaged blood vessel, and it's a formation of a platelet plug. So platelets are activated and stick to the injured blood vessel because of a protein called Willebrand's factor, which is also a chromosomal disorder, which is a genetic disorder. Excuse me, von Willebrand's factor, and this factor is produced by the cells of the vessel wall. The platelet plug develops in 3 to 7 minutes. Next, clotting factors are activated either from the intrinsic or from the extrinsic pathway, and proceed in a coagulation cascade to the common final pathway. The difference between intrinsic and extrinsic pathways has to do with the initiation of the clotting factors. Lab work that you need to know and understand, Rachel, and you will need to understand the prothrombin time, the international normalized ratio, which we refer to as INR, the activated partial thromboplasm, and the fibrogen, the platelet count, the D-dimer. Here, let me see what other labs you need to be exposed to. So these are the labs that are used to assess plasmin and thrombin levels, which are altered in DIC. So that is a condition referred to as disseminating intervascular coagulation, and then genetic counseling is recommended for primary prevention and screening prior to surgery or procedures. So, so it's important to ask these questions during that pre-op time. You know, if your patient has any blood disorders, obviously full, blood panel will be drawn on your patient with lab work and whatnot. But also questioning the patient is important as well. All right, so question 2, sorry. Make sure you answer this in your Word document. And the next concept is a concept of mobility. All right, this mobility is dependent on the synchronized effects of the musculoskeletal and the nervous system as well. So they work in correlation. And with the musculoskeletal system, it's important to have adequate oxygenation, perfusion. Cognition is important as well, right? And specifically, mobility requires adequate energy, right? We need energy to move. Adequate muscle strength is important. Underlying skeletal stability is important as well. So a lot goes into mobility. Think about joint function and neuromuscular connection, right? To carry out the desired movements. So the alerts that our brain get through the spinal column, right? There's a thinning of repeat vertebral disc. There's complications that occur with the spinal column and onset of kyphosis, right? Compression occurs with the process of aging. Bone density decreases as the process of aging as well. So they become brittle and fragile. In females, it leaves our older population more susceptible to fractures. So that's important to keep in mind with mobility as well. The cartilage becomes more rigid and fragile as well, and there is a loss of resilience. Ligaments, right? They become thin. So lots of complications that occur with aging. Muscle mass and muscle tone reduce significantly as well in the later adult years. So all of these changes, it's important to keep in mind that all of these changes can result in mobility impairments, which is an attribute to reduced range of motion and pain as well in the joints, reduced muscle strength, and increased risk of bone fractures. It's also important to note that immobility causes cardiovascular system issues with decreased decreased cardiac output, right? Orthostatic hypotension can occur as well. Venous stasis can occur as well. And it's important to know with orthostatic hypotension how we move our clients, right? Because that can cause a fall, it can cause injury as well. Respiratory due to immobility has reduced lung expansion. It can cause atelectasis, right? And pulling of respiratory secretions. If they sit there for a while, guess what? That can lead to pneumonia. Um, the musculoskeletal system is affected by immobility. It decreases the muscle mass, atrophy occurs, right? Contractures can occur, and bone demineralization can occur as well, right? All the minerals that our bones need is not occurring with old age. All right, now the skin is plays a significant role as well. So, that system can be impacted by immobility, and the skin breakdown is huge. The GI system is impacted by immobility as well. It can lead to constipation, right? A lot of people don't know this, but the urinary system can be impacted as well, because of calculi, right? Stones in your bladder and your kidneys. So you can get a calculi infection as well, and stasis. That's why our older adults are at risk for UTIs. So when we're talking about mobility, what's the most prior intervention? So what are some preventative measures? Regular exercise, right? Regular exercise can be primary intervention, and then secondary can be screenings, right? So there's this DEXA scan for females at the age of 40 or above that can be done for osteoporosis. Um, and then they'll do like a fall risk assessment, right? So we do have a little activity for you guys to complete as well to better understand those assessments. Okay, and we're going to move on to the question that you need to answer on the Word doc. Okay, and our next concept here is comfort pain, right? That first quiz that you guys took in lab had a lot of questions regarding pain. And, I looked at the questions, and a lot of people got a question regarding addiction incorrect. And just remember, whatever the patient says their pain is, that is what we have to treat, right? We're not making any judgmental decisions on their past. We are trying to help them overcome, get through this surgical operation or get through whatever pain they have. So we will be an advocate for them, call the physician, and go from there. All right, so the concept of pain, comfort or pain, um, is the ultimate responsibility for comfort, um, which is a more positive concept, right? That WCC has adopted. So the International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential damage or described in terms of such damage that your patient might experience. Then there is a clinical definition that has been around since Margot, I believe it's Margot McCraffery, and this was adopted in 1968, which was accepted worldwide, and references that pain is a highly personal and subjective experience. So pain is whatever the experiencing client says it is, existing whenever they say it does. So that's important to note. Pain is an eloquent network of cells, fibers, and organs known as the somatosensory system, which receives, transmits, and interprets sensory information that is transmitted. They're specialized sensory receptor cells. They carry specific types of sensory information, such as the vision, hearing, touch, heat, and cold. There's the perception of pain, along with different anatomical pathways depending on the information that's carried. The cells of free nerve endings in the skin and peripheral organs that are somatosensory receptors as well. For the sensation of pain are known as the nociceptors, and these are found in all tissues except the central nervous system. Tissue injury can activate these nociceptors as well. So that's important to note, because it transmits pain information to the somatosensory system, which is a process known as nociception. And remember, the brain will interpret, what it receives. This, if it receives information, it can interpret it as unpleasant, a painful sensation as well. It is known as the nociceptive pain, which is a protective mechanism. So that's also important to note. It alerts our brains to potential or actual tissue damage as well. Examples of nociceptive pain include pain from a sunburn, surgery, or trauma that may occur. Somatic pain is characterized as a sharp pain that is well localized to a specific area of injury. Then we have visceral pain, which arises from within the body cavity. It's most commonly the thorax, abdomen region, pelvic region. And then we also have the neuropathic pain, which is a burning, stinging, tingling sensation as well. We use, different pain scales. The most famous one is the numeric scale, 0 to 10. There can be the phase scale as well, which is different. And these phases record the level of pain. There are also sorts of pain management, right? Opioids, non-opioids, such as Cordilac, NSAIDs, any type of adjunctives that can be used, such as gabapentin or some, I've seen anti-epileptic drugs used as well to treat pain. Acetaminophen will be added to opioids as well, right? We have, Norco as well that has a little bit of Tylenol in it. And then there's other therapeutic means that we can do to control pain. cold repositioning, right? Complementary alternative medicines. So like heat, cold therapy, repositioning, herbal medications, over the counter medications as well, that can help treat pain, massage, biofeedback, acupuncture is a big one. Um, Complementary therapy as well. So lots of different scales that we can use to treat pain. All right, here's question 4. And please record question 4 on your Word document. And here is the learning outcomes for module 4. Thank you so much. Take care.